We will get started and I will brief anyone else who joins later. Welcome all to the weekly huddle. My name is Anup Agrawal. I am a practicing cardiologist at Care Hospital, Banjara Hills. My co-host for the session, Dr. Praneeth, he is driving right now because we were stuck in a case and I reached home, he is still on his way. The weekly huddle, the way the session started is basically the idea behind interacting with each other with an aim to understand our thought process. And what I mean by that is every decision, every medical decision that we take for our patients, we all have our own rationale of why we are doing it. It sometimes is science-based, sometimes it is experience-based, sometimes it is just practice pattern. Things which we think works, and to the best of our knowledge, we apply to our patients. Each one of us, we have our own quirks, we think our own way. So the huddle essentially is to bring out those practice patterns, understand each other's thought process, and maybe in doing so, learn a few tips and tricks of how we practice medicine as a general. The weekly huddle is not just about clinical medicine. We do talk about things outside of clinical medicine like finances or quality control or those kind of stuff. Today's topic is to talk about outpatient management of SARS-CoV-2. And the reason why I chose outpatient is because majority of our discussion that I saw in the last few weeks have been mostly condensed towards acute care management, because that is where the outcomes are assessed, patients are sick, that is where most of the research is happening, that's the action, that is a war zone. And that's probably is equally, if not more important. But we do understand that almost 80–85% of COVID patients, they do not require hospitalization, and majority of them would stay at home. So while acute care medicine and critical medicine is important for COVID management, what is also important is how we counsel these 85–90% of the patients who stay at home. What are the prescriptions, both pharmaceuticals and non-pharmaceuticals, that we are prescribing? Me being a cardiologist, I don't see or manage a lot of those cases, but once in a while our old patients, they do come to us with COVID positivity or their family member is COVID positive. And we are bound to give them some suggestions that we think is the best. So having said that, I thought let us bring all the doctors from various specialities can share their thoughts. Few of you are the frontline worker of how you treat COVID. And then there are cardiologists like me who once in a while stumble upon COVID and do need to treat. Certainly we are not as actively involved in the intensive care management, and that is not the topic of discussion. The way I start the session is I always bring up a clinical question, which is an actual patient case. I ask my colleague, Dr. Praneeth, to give his impression, and then we open the session for everybody else to give it the input. It's not a speaker and audience model, it's a total panelist model, which means each one of you, your value is equally important for the session. So if you have anything to add, either you can raise your hand or unmute yourself and share your thoughts. I do like to invite some of the special guests whom I've invited, and they have gladly been part of today's session. Dr. Naval Chandra is here. Dr. Naval Chandra is an internal medicine physician at NIMS.
Hi, good evening. Sir. Yeah, nice. Thanks for having me, Dr. Anup.
Thank you, sir. Thank you for being here. Sir, I'll keep all the guys muted and unmute when you want to speak, and if you yourself can unmute just like the way you did. I think that keeps the quorum good. Let me welcome Dr. Guruprasad. He is also an internal medicine physician at Care Hospital in Banjara branch. And Dr. Srirang, he is an internal medicine physician at Omni Hospital. I was expecting Dr. Rafi. He has not joined yet. Hopefully he will join in the next few minutes. Dr. Rafi is a pulmonary medicine physician at Care Hospital as well. And amongst the audience, we have Dr. Kartik Munta as well. He is a critical care physician at Yashoda I believe, Somajigura. Correct me, Dr. Kartik, if I'm wrong. I think you're at Somajigura, right?
Yes, yes.
Yes, perfect. Thank you. And then we have Dr. Chandramukhi. She's a cardiologist. And if I'm just going through the list, Dr. Johan, he's a cardiologist, both at Care Hospital. We have a few residents. And that's pretty much about it. Dr. Vrinda is there. She's an endocrinologist, and she's my wife, joining from the parallel room. Okay, so Praneeth, my clinical question to you is, and then I'll open it for discussion. This patient had a video consultation with me 2 days ago. She's my old patient, non-diabetic and hypertensive, takes triple therapy for hypertension, and diabetes is moderately controlled, not very nicely controlled. She, unfortunately, her father-in-law passed away recently with COVID, and she got herself tested and she found herself positive as well. Her main complaints are low-grade fever and myalgia. Other than that, she is pretty much okay. In her household, she has her husband, who is also positive and is asymptomatic, and they don't have any kids living with them. She's a 50-year-old female. Before she approached me, she approached a local physician, and she already got few sets of labs done. I'll just brief you those labs. She had a IL-6 level done, which was 7.8, with a reference value of that lab being less than 6.4, so mildly elevated. Ferritin and D-dimer are normal. Her troponin was checked for some reason, that is normal. ESR was slightly high at 42, creatinine is 1.2, total leukocyte count 8,000 with 36% lymphocytes. Other investigations I'm not briefing because those are probably not relevant. Clinically, she is stable. Her saturation is about 97, 98 at room air. She is not tachypneic. She otherwise feels okay. She's trying to isolate herself along with her husband at home. Her purpose for video consultation was, what should I do other than this? Because her local physician told her to see a cardiologist or some COVID expert. So Praneeth, a case like this comes to you, a 50-year-old female, not that much symptomatic. Lab test, I told you, a little bit high IL-6, otherwise okay. And she's on medicine for hypertension and diabetes. How would you take up this case? Would you admit, first of all, would you admit this patient?
No. So I won't admit this patient. My understanding of COVID, I would look into. My understanding is whether they have lower respiratory tract involvement in the form of pneumonia, and if they have pneumonia, then do they have any hypoxia? That is, your saturation being low. Unless they don't have any saturations which are low, I don't think they qualify for admission. Both from the clinical standpoint of view and also from the availability of the the bed availability and etc. taken into consideration. So I won't ask them to get admitted unless they qualify these things. Now coming to this patient, about she having only mild symptoms of some fever, myalgias and all, saturations being normal, and even investigations, no red flags so far. I would suggest her to stay at home, keep monitoring her, watch for any new symptoms, any worsening fever, continuing fever, any worsening breathlessness, or any new symptoms or signs which are uncomfortable. So keep checking, and unless they are not there, then I would ask her to just stay at home and keep monitoring herself.
And Praneeth, any drug that you would prescribe her at this time other than paracetamol?
I'm not for prescribing any other things. Most of them already get a prescription by the local physician about the zinc, vitamin D, some azithromycin, and etc. I'm not comfortable, also because of the ignorance and because of the lack of proper evidence. So if they are comfortable or who are already taking, then I would ask them to continue. Personally, me, if as a primary person, if I have to take a call, I would not. Hello.
Okay. Yeah, Praneeth, looks like we lost you just for a second. I get your idea. I think I get your thought process. Let me invite somebody else here. Sorry, as I was going through the list, one information I did not mention, which is equally important, is she did have HRCT at the time when she consulted me, and that was reported as score at 3, whatever for that means. I don't have the images, I just have the report. So I'll open this discussion. The questions are mostly revolving around how to counsel these patients to the best of what we know how COVID works, both in terms of checking their pulse oximeter. So should they sit with the pulse oximeter in their finger? Should they check it every hour? Should they check it once a day? What is the role of blood pressure check in these scenarios? Other than paracetamol, is there anything else we can do for fever management? And all the prophylactic therapy, not prophylactic per se, but early therapy, like in terms of be it hydroxychloroquine, be it in terms of ivermectin, in terms of azithromycin, or vitamins or whatnot. So I think a lot of these discussions are there. In the grand scheme, how much does it matter or not? I don't know. But let me invite Dr. Naval Chandra on this. Dr. Chandra, how would you approach these kind of patients? I'm sure you are seeing this on a daily basis. So
Hi.
tell us about it.
So here we have, how old is she?
Sir, she is 50-year-old, 50 years.
Okay. So the important thing to remember here, doc, she's got 2 risk factors of diabetes and hypertension, right? Now, if you're going to stage her illness, she comes under 1B, 1C. That is how we stage. We have stage. So when it comes to 1A, they're absolutely asymptomatic. They require none other than the B complex and the zinc, the vitamin D, calcium, and they are advised home isolation. If you look at 1B, they're mildly symptomatic. Here, this patient has got some myalgias and fever. IL-6, I would not give any importance to at this stage. I would not consider it in my treatment protocol as something rightly being done at this stage. Secondly, if she's a diabetic hypertensive, that is risk factors, she comes under class 1C. That is mild symptoms with risk factors. So now when you have a patient with mild symptoms with risk factors, as per the guidelines we have created at NIMS, she is a candidate who is advised either home isolation or getting into a isolation ward at the hospital. Now, as long as the treatment goes, other than the B complex, the vitamin C, zinc, and so forth, there are plus minus on this new molecule called favipiravir, where some evidence, not probably good evidence, but whatever little we have, because COVID is evolving, we are all evolving with it. We don't have enough data on this, but whatever little we are placing it, plus minus, it is to the discretion of the physician whether he would like to start this. But the role of favipiravir comes as early as possible, because that is the viremic phase. The first week is the viremic phase, right? Now, the second thing is, we at our institute, or if you have a diabetic hypertensive with myalgias and fever, we would definitely recommend either a doxy with ivermectin or HCQ. Now, HCQ of late, we as a protocol, we do follow it because we are compelled by our government policies. But in our experience over the last 6 months with COVID, we are very happy treating such patients with doxy and ivermectin to start off with the 4 drugs other than these. This would what I would recommend. The other thing is that HRCT at this stage, again, is early. It has been probably too early to have planned a HRCT, and I would not have recommended HRCT at this stage. This is my call on this patient.
Perfect. Thank you so much, sir. Thank you for being very precise, up to the point, and also covering pretty much everything that we should be. Dr. Guruprasad, I think that you have a complete fort of COVID in your hospital, and I'm sure you are doing video consultations for these kind of patients. How would you take this patient?
Yeah, thank you, Anup, for inviting me for this meeting. Couple of points I do agree with Dr. Naval, what he spoke about, that the risk factors of the patient are extremely important for us to triage the patient into what you're going to plan for her, especially for the patient in point in case. So this lady, especially with the latest US FDA ruling that remdesivir might not be, you might not wait for remdesivir till hypoxia sets in. This patient you mentioned about poorly controlled sugars, right? So that is something I would keep in mind, because once the viremic phase is over, she'll go into the hyperimmune stage, which is approximately day 8, day 9, and then extends up till day 14. So if you start an antiviral at that point of time, you would have probably missed the bus, and you would be thinking about giving her, something like tocilizumab or steroids, which are going to worsen her sugar control further. So I would actually be compelled to advise this patient to come into the ward for isolation, for admission, and probably also counsel the counselor for initiation of remdesivir. Because favipiravir, the guidelines, the studies are not very robust, because most of the studies have been done for remdesivir. So for this kind of patient, in all probability, because of a poorly controlled sugars, age more than 50 years, and CT, as I agree with Dr. Naval, is that CORAD-5 just says about the fact that it is most probably COVID. It doesn't talk anything about the severity of COVID. The severity of COVID is a different scoring system altogether. It's called a CT severity score, which is totally different. So people think CORAD-5 means, oh, it's a severe COVID and the CT is bad, so you need to admit the patient. CORAD-5 says that it is basically most probably a COVID and you need to go for a test. So, I would actually try to counsel this patient for admission for initiation of early antiviral therapy, mainly because of her age, and second, her comorbidities like diabetes, which is poorly controlled, and hypertension.
Perfect. Thank you so much. So, sir, early.
Dr. Guru. Yeah, actually agree totally. I just meant in general terms antivirals. With our experience also, we are using a lot more remdesivir in the first week, as what rightly you're mentioning. I would prefer the same over the favipiravir, what evidence base we have also. And another thing is, I think Dr. Anup, you mentioned it's CORAD 3, not 5 also. So
Yes,
again, it goes to show that it's probably done early in the line of his the patient's illness also. So that would not hold any bearing to me at this stage.
Perfect. One more thing, and let me see what I wanted to add. Oh, that fleeting thought, I forgot now. Okay, let me ask Dr. Rafi. Dr. Rafi, what do you think about this CORAD 3, CORAD 5, which partly Dr. Guruprasad answered already? These patients, and I'm talking purely from the outpatient standpoint, these patients who are on the video consultation with you, CT says CORAD 3 on, let's say, day 3, day 4 of symptoms. Saturation is okay. What is there any meaning to that, or should we be looking at severity score? Could you guide us through that? What do you do?
Listening to the Dr. Naval and then Dr. Guru been chipping in as their opinion, I think I agree with the both. With the new guideline is asking if the comorbidities are there, I think not to wait for the oral medication antiviral. I think straight away jump to the, here is that one thing. Another thing I think Dr. Naval is pointing it out is a CORAD 3. This is where I think actually as an OP based, hello? Hello?
Yes, sir. Please go ahead. There was some cross noise.
Okay. So CORAD 3 is the one which actually begs the clinician, let us say the online consultation. Physically, the patient is not there. You are not actually, converting it into an IP. CORAD 3 is actually saying that they're indeterminate. So that means you need to determine whether it is a viral, what we are thinking of this pandemic. That is when I think it makes more sense to ask that patient to go for the RT-PCR. So to even start for the antivirals, if it is in the indeterminate stage, it is a clinical decision to go for the one additional test like you can go as an OP basis. RT-PCR would make one of the additions into that patient. So after that, I think maybe you can wait a day before you can actually check for that and then take a call. So because it is still evolving, probably this patient, I think what I am seeing, maybe in the 7th, 8th day, maybe past just 1 week, possibility of inching up to a 1 week course of her illness, probably. If I am not wrong, yeah.
Yeah, so the onset is difficult because, she had a family member who was positive who recently passed away. So I'm sure she was exposed for about a week, 10 days, I'm guessing.
Yeah, so it's a good time to go for, because CT is not showing completely evaluated, confirmatory way of saying that it is a COVID. But I think to go for the RT-PCR on an OP basis itself in a patient. But here in this case, even if it is Corat 3, having more comorbidities like uncontrolled, probably diabetic, her condition is diabetic and all, I think probably also can be asked to be admitted for an isolation and then send it a sample. So it is a catch-catch situation. I think patient is not ready to get admitted. I think probably you would advise go for the RT-PCR as an OP basis and then check for it. And then you can actually see the disease to be evolving in the next day or two. Meanwhile, I think you can actually, a symptomatic treatment can be done. But that point of time, if you're that point of time, I think probably give about another couple of days. So yeah, and then for the admission or otherwise an oral prescription. If you're going for the oral prescription means obviously favipiravir. So once the RT-PCR comes back, if it is positive, I think because of her comorbid conditions, you would suggest for a home admission with the isolation room and then think about remdesivir. That's how I should go about this case actually, because it is Corat 3. If it would have been a Corat 5, and then a lot of comorbidities are there, like what we are seeing, hypertension and diabetes, probably we would have to suggest for the admission.
Perfect. Thank you, Dr. Rafi, for that. Yep. That makes perfect sense. Let me bring Dr. Srirang here. Dr. Srirang, I have 2 questions for you. Number 1, how would you take this case that I briefed? And number 2, what is this oseltamivir? Is there any role of oseltamivir early in the case of COVID, which we have been using for common flu?
Good evening. Thank you for having me. Am I audible?
Yes, sir, you are audible.
Yeah. As regards this case, I think broadly speaking, we all agree anybody who's having comorbidities needs to be watched more carefully for development of problems later on. Again, as regards favipiravir, the evidence is not so much robust. There have been reports where people have found people using favipiravir having a lot of bradycardias as well. If they are on other drugs, then it's sometimes difficult to know whether it is combination with other drugs or an underlying cardiac problem which they are having. So we've personally encountered a few patients who had bradycardia, so not using it very often. As regards remdesivir, although the FDA has recommended that now we use it on a broader section of people, maybe early on itself. But with our population and the kind of comorbidities we have, I'm not sure whether we can actually do that even if we want to. So careful, close monitoring of the patient would be there, and that initial therapy as suggested by the former speakers can be good enough for this patient, but closely monitor. And then when you know that it is going to be a problem at the end of the first week, any slightest symptom, then you will probably can add in a steroid or a remdesivir. Good control of diabetes and hypertension is equally important to note, and then they need to be regularly in touch with the physician, maybe every alternate day, or any slightest desaturation, even at rest or after a walk about 4 minutes, there's some desaturation of more than 3%, they need to contact urgently. As regards oseltamivir for COVID per se is not useful. We all know the other drugs which are also being used are repurposed drugs which have been used for resistant influenza or otherwise. So oseltamivir I would not recommend for COVID at all. It is something like a lack of a very good drug like oseltamivir, which is there for influenza, and lack of that drug for COVID, which is making all the problem. But oseltamivir for COVID may not be a good idea. If at all somebody presents with influenza like illness, otherwise empirically you can start them on oseltamivir in a setting where you are suspecting swine flu, which is there in that setting, but not in the setting of COVID.
Thank you so much, sir, for that wonderful ideas. Let me see. So one of the questions that I have is early on, if we talk about initiating therapy early on with remdesivir, that particularly mean that we are advocating admitting these patients. Is that right, Dr. Guruprasad? Am I reading it right, or is there any role of you giving remdesivir in the hospital at home as well?
No, there is no role of remdesivir as an outpatient therapy like OPAT. I'll give you a case scenario. See, we recently had one gentleman who was 70 plus, who had an angioplasty some years back, and almost was gotten with a pulseless activity, and he was actually taken up for angioplasty, and then subsequently he came out. And this gentleman is also diabetic, also hypertensive, with a borderline renal function, comes with a positive COVID report, and he's having fever with myalgias. So the question now is that there's a case scenario I'm telling you. So whether I give favipiravir and wait and give doxycycline and wait, or do I admit this patient and give remdesivir so that I get over the viremic phase and don't wait for the hyperimmune phase to come, because this gentleman is going to go through a torrid phase if I wait till that time. So my idea, any antiviral, is that you hit early. Even when swine flu was going on, when oseltamivir was in question, the oseltamivir works in the initial 24-48 hours when you hit the virus hard. The moment the body's immune system goes maladaptive, your bus is you missed the bus, and then you are thinking about giving steroids and tocilizumab, and then your HFNC, all the critical intensivists come in, and then you are really in trouble at that point of time. So in this patient, we admitted the patient. There's a lot of resistance about why are we using remdesivir for a patient who is not hypoxic. Then luckily the US FDA just before night came up with this guideline. So I had this guideline to show people that, okay, this is the viremic phase, I'm going to use remdesivir. We admitted this gentleman, gave him remdesivir, and he is home and texted me that I'm fine, thank you so much. And he's completely afebrile. His acute inflammatory markers have come down, CRP has come down, IL-6 has come down. So, I mean, you have to look at the patient clinical scenario where you are going to initiate remdesivir. Same 40-year-old man comes with no comorbids, with just fever, body pains. I'll just tell him to just sit at home, isolate himself, and for whatever it is worth, probably start him on favipiravir, and just monitor his uric acid and his probably liver enzyme levels. One more thing, Anup, I would like to make, because there's a big group and a lot of physicians here, is that in the first initial days, people keep asking for IL-6, D-dimer. I would say a good peripheral smear. If you have a good peripheral smear, a pathologist who can see a good peripheral smear, if you are getting reactive lymphocytes up into the body and there is no neutrophilia, most probably this patient's inflammatory markers might not actually rise. That's something a good pathologist will tell you. If there is lymphocytosis and there is no neutrophilia, that means you're fairly out of the woods at that point of time. So doing this IL-6, a lot of labs I've seen, they store the sample, IL-6 comes falsely elevated, they initiate on steroids, clinically the patient is fine. So I think there's a perfect podium to discuss about this thing. I'm sure all my fellow colleagues have also come across this situation where IL-6 is in thousands, but the patient is fine. So why ask for a test on which you're not going to act upon? Probably ask for a peripheral smear or C-reactive protein at the most, if you want to.
Thank you, sir. So let me bring Dr. Kartik in here, and then we'll take your opinion. Let me see. Dr. Kartik, so again, the question for you, the first question is the same, the clinical scenario that I told you, how would you take this patient? And being in the critical care, how do you take this IL-6 into account to patients who are at home? And the third question is, which is asked by Dr. Shastri in the group, is interferon beta available in India? And if it is available, anyone using the drug? So 3 questions for you, Dr. Kartik, please take it.
Yeah, so many of speakers saying about this home isolation, and totally agree with it. But I would keep this patient really under close watch because of the comorbidities. Otherwise, he would have been ideal to be at home isolation. The treatment management would be the same what Dr. Guruprasad has suggested. But if you are treating this patient at home, then definitely administering remdesivir is an issue there. So I would continue favipiravir and the other supportive drugs like vitamin C, zinc, and vitamin D, and keep a close watch on his saturations and ask him to monitor his saturations, do a 6-minute walk test and see how the saturations are behaving like. CT was a bit early in this case. I presume he could have waited. And coming to the IL-6 level, I totally agree with Dr. Guruprasad had to say. IL-6 at this stage, at the very outset, was not required. But considering his his comorbidities and all, in a practical world, yes, and they are done. The inflammatory markers are done, and they are done at a baseline. But the clinical scenario is the paramount importance, and the lab data, whatever it is, if it the clinical scenario matches it, then it's going to make a difference. Otherwise, the fallacies and the problems with storage and IL-6 coming falsely high is a known entity. So I would not give much weightage to the IL-6 parameter as such. Unless until patient becomes dyspneic or patient starts having symptoms which are not regressing in spite of your antivirals, then IL-6 helps us in predicting patients who might have a rough weather or a torrid outcome in a coming days. Otherwise, IL-6 is not of much importance in this specific stage where you're talking about. And interferon gamma, no, I have no experience about using interferon gamma here in COVID cases. Yeah.
Thank you, sir. So the question was for, I don't know about interferon gamma or beta or anything. The question was about interferon beta. Anyone who has any idea about this particular question, interferon beta availability and use in COVID? Chandra?
No, I don't have any idea on this, Dr. Anup, fortunately. So anybody else would share the experience? I don't think it's available, Dr. Anup. I don't think they're giving it here.
Okay. Yeah, I have not come across use of interferon beta, particularly in COVID. It has been typically like the typical critical care cytokine drug. But there was a recent Roche which published their data for IL-6 inhibitor, which was negative. I believe last month they published. And the Biocon data is already with the TOSI is already questionable right now. So and there are new, I wouldn't say editorial, but comments about how that cytokine storm thing is also being questioned. So a lot of these things are coming up, but they're mostly for acute management.
Coming back to this case of home isolation and this patient of yours, I think another 2 points I would definitely like to add is one, Dr. Rafi mentioned gold standard RT-PCR. Please look out for the cycle threshold value. CT value for us has given a lot of help over the last 6 months with our experience. The higher the value, you can always predict it's only likely that the patient may have a milder disease or a milder course. If the CT value is very low, then you know that you are looking at a patient who may have a stormy course. Another important thing is baseline NL ratio. Dr. Guru also mentioned. I think NL ratio is a very, very important marker for us. We go by NL ratio of less than, anything more than 3.5 or absolute lymphocyte count less than 1100 is also a marker we find that which will help us detect or tell us that the patient is going to have a stormy course or not. So these two, I just wanted to add these 2 points.
Sir, you mentioned about cycle threshold. I already love you for that because cycle threshold has been something which is again very discussed topic. I do read about it and I think it is valued. The only problem is routinely we don't get this number. So I think we'll have to reach out to the lab.
Wherever you get, that's why when you go to a decent lab or a good lab, they do give, or sometimes you got to ask for it rather than, they just giving it or not, because that will help us.
Dr. Guruprasad, are we getting CT? Yes, please go ahead.
That's what I think I little differ with Dr. Naval Chandra on the CT threshold, the cycle threshold importance. There was a recent article on this Sunday in the Hindu about the cycle threshold, and I absolutely loved that article. And actually, then I went through it. I was really piqued by it, and I thought I should go through it. The CT value actually, if you think that the lower the CT value, then obviously the patient will go into a torrid course. Is not so. Actually, the CT value predicts if the patient is going to be infectious to the society, or how infectious the patient is going to be. The CT value doesn't correlate with, and I can probably share with you those studies which were there. doesn't predict the severity of the illness in any way. I think we should really read this in very, very carefully.
It's
So
basically just the viral load, right? It basically reports viral load.
So what it does is, what it tells you is, if a CT value, suppose it comes in positive in 20 cycles, I can say this fellow probably will be a super spreader. He will go and spread to the society. But it doesn't tell me this person is going to get more sick because the CT value is lower, or he came in 20 cycles or 15 cycles, or for the matter 30 cycles. So I found very interesting, because I also felt before that the CT value actually shows the severity of the illness, but it's not so actually. And there's a lot of data on that right now. I can probably share in the group if you want to. The second point which I want to tell was that we should be aware about the sensitivity of a particular test which you're asking for. So there a lot of times when you come across a patient who's Corad 1 according to radiologist, but he got RT-PCR done and it came positive. And the other way around, the patient is Corad 5 and we have done 2-3 PCRs and it is negative. So we need to understand that it is the clinical scenario which we're dealing with, the pandemic era which you're living in, then subsequently look at the case scenario and then treat accordingly.
Sir, my question to you was, do we get CT value in our report, or can we ask for it?
We can ask for it. We can ask for it from the lab from where we are getting the reports. They do mention the CT value to you.
So the tenant will give, because most of the report I see, it doesn't show CT value, right?
You need to ask for a CT value.
Okay, then they will report it. Okay. Let me bring in.
Come in here.
Yes, sir.
Regarding
please.
the CT value.
Yes, Dr.
The ICMR has issued a recommendation that CT values are not to be used as markers for severity of the disease or spreading, because of lot of confounding variables which can be there in measuring the CT value. It can get affected by the way the sample is processed, how long it has been taken, how it has been stored. So although the logic behind thinking a low CT value is a severe disease or a higher viral load is fine, but in clinical practice that value is not to be used as an indicator or marker of severity of the disease. That has been a recommendation and a notification issued by the ICMR as well. So although that holds practically, and even with a lot of webinars we have attended with the microbiologists, they also emphasize that CT value, although it tells you that viral load likely to be high, but does not correlate with the clinical correlation because a lot of confounders which are there.
Perfect. So, sir, thank you for bringing that up, because as we know that the other thing which spreads faster than virus is propaganda, and currently there are a lot of social media propaganda going on about saying that if your CT value is more than this, then don't believe your doctors, you don't have COVID, they are making money and all those things. So I think the CT value is something which is very important for us to understand and also communicate to patients. Let me bring in Dr. Chandramukhi here. I think she also has some comment to make. Dr. Chandramukhi, I'll ask you this question. In fact, there is a question on the group. So I'll ask you that question. You can answer that. And then if you have any comments, you can put that. So the question here is, any special instructions post PTCA asymptomatic COVID positive, otherwise clinically stable? So a patient of yours who is post PTCA comes in, who is COVID positive, but otherwise asymptomatic. Is there any special instruction you do for those patients? Let's say the guy got PTCA last week or something. Dr. Chandramukhi, please go ahead. Yeah.
Yeah. So post PTCA patients, I think LV function will be important in these cases. So if LV function is normal, and if even if the PTCA is done, we can consider other comorbidities like diabetes, hypertension, uncontrolled sugars. But if there is a moderate or severe LV dysfunction, then definitely we need to give special instructions to the patient. And special instruction will be, we should tell them to monitor the symptoms like any alarming shortness of breath, whether if it is there, or they have to check their saturations daily, like 8 hourly, and if there is any slight drop in the saturations, then they have to get hospitalized. And I want to ask one question, like as you have brought about the patients who have undergone PCI, if patient is having LV dysfunction, do we need to hospitalize these patients for remdesivir infusion, even if they don't have symptoms of shortness of breath, or even if they are maintaining saturations? So because the Guruprasad sir has given one case scenario where even though the patient was not having shortness of breath or drop in saturation, that patient was hospitalized and he was given remdesivir in infusion. So in patients who are having coronary artery disease, LV dysfunction, or patients who are having heart failure and LV dysfunction, do these patients need hospitalization even if they don't have any shortness of breath or drop in saturations?
Perfect,
I would
ma'am.
like
I'll
to just
address.
come in. Is it all
Yes.
right?
Yes, Dr.
Although
Srirang, please go ahead.
we're
Dr.
talking
Srirang.
as risk factors, comorbidities as important risk factors, comorbidities guiding our treatment patterns. In clinical practice, we have seen a lot of elderly patients with comorbidities doing very fine without antiviral, steroid, etc. And a lot of young patients reacting very abnormally and then having a cytokine storm. So although we need to be more cautious, more watchful, more closely follow patients with comorbidities, the presence of comorbidity itself does not predict the adverse outcome universally. So we need to be very cautious in using all other drugs just because somebody has a comorbidity. A lot of times we are seeing somebody having even hypothyroidism is labeled as a comorbidity and that is given as a cause that okay, he had hypothyroidism, that's why it's worsened. So we need to be very careful regarding this comorbid condition.
Thank you, sir. Chandramukhi madam, I'll address your question. Let me just ask Dr. Johan. Dr. Johan, this patient got IL-6 tested as an outpatient. I have two questions for you. Number one, do you test IL-6 in your patients or other so-called COVID markers, which is D-dimer, fibrinogen, or CRP or whatnot? What do you prefer in those cases? And my second question is, most of your patients, I'm guessing, are on ACE inhibitors and ARB. How do you handle those drugs? There was a lot of heat and debate early on about this. And again, we are talking about outpatient management, not very sick patient, maybe mild symptoms. Dr. Johan. Dr. Johan, I'm not able to unmute you. Dr. Johan, I'm not able to unmute you. No? Dr. Johan, I'm able to unmute you. Okay. Let me switch gear. Ask an open question for Dr. Chandramukhi. For Dr. Chandramukhi's question. So, patient with low EF, previous history of heart failure, right now stable, COVID positive, absolutely asymptomatic. Let's say 40% EF on optimal medical management, NYHA class 2 doing okay. Do these patients need routine admission for COVID positivity? Dr. Kartik, what do you think? You think we should admit all these patients, and then I'll open it for anybody else to comment on this.
Can you come again, please?
So the question here is, a patient, let's say 50s age, this guy has low LV function, previous heart failure, but now stable, NYHA class 2. He is COVID positive, but asymptomatic. Do these patients need admission? We know that low EF and heart failure is very high risk marker, but in a person who is otherwise stable, how do we handle this?
Okay. So considering all the comorbidities that you have now, I would definitely admit this case because this case is coming with a serious bit of risk factors. And even according to the national guidelines, the exception is made to those patients who are mildly symptomatic but have these severe comorbidities. They are to be closely monitored in an institutional care. So I would admit this case and I would keep him in the monitors on the close monitoring.
Anyone else who wants to comment on this? It's open for discussion. Anybody else who has any thoughts about this patient?
Dr. Anup?
Yes, sir.
Raghu here. Can I talk?
Rafi, sir. Welcome.
Oh, I've been here with you for the last half an hour. I joined a little late.
Okay, yeah,
Yeah,
for some reason I couldn't see you. Yeah, please go ahead.
Yeah, I also agree with the previous speaker that all those patients who have a compromised LV function with COVID positive, despite being asymptomatic, I think they're better off being admitted because if they start deteriorating because of the involvement of the myocardium by the COVID disease, they may deteriorate very rapidly and may not have time. And if you have to depend on an emergency admission and there are no beds available, then planning their treatment could be much more hazardous. So I think they should be admitted. They should continue all their routine medications. I do not think we need to change the medication just because they are COVID positive. But being in the hospital, early administration of oxygen, if required, may all tilt the balance between survival and death. I also wanted to add another point on the much discussed CT, that is the cycle threshold. I've seen a few patients lately. I read a blog by the chairman of Biocon, and I think I showed it also to you, Dr. Anu, about her own travels with COVID, where she mentioned about the cycle threshold and all that. And that was the first time I heard about it. Today, in fact, one of my patients called saying that Munta labs have given a cycle threshold of 18, which means that the virus load is very high. And I also read the article that Guruprasad mentioned, very well written article in the Hindu, which I in fact sent it across to a few people. And they very clearly say that this is still in a very gray area, because the cycle threshold can markedly vary depending on how the swab is collected. And in the same patient, they have shown that the cycle threshold can be different if saliva is collected and or the nasal swab is taken. And its reproducibility is as bad as the reproducibility of strain in assessing cardiac damage. So these are the 2 points which I want to clarify on. I have a question for Dr. Guruprasad. This is going to be a slightly long one. So far, I've seen that in Hyderabad and also in other areas where I've interacted with, different treatment regimens are being used. Like, for example, some hospitals in Hyderabad are directly starting oral favipiravir. Some hospitals are even using tocilizumab. And we have been very consistent in using remdesivir wherever patient develops desaturation or he's very symptomatic, or if the comorbidities are very high. And I've seen a few prescriptions of oseltamivir also. That is the antiviral agent. Supporting them, I've seen a lot of ivermectin being used, especially in our hospital, which is not being used in, say, Mumbai and Delhi. So can I have some clarity on what are the current concepts of ivermectin and of doxycycline and azithromycin being used routinely for all patients, regardless of whether they are likely to be hospitalized or continue to be as an outpatient?
Thank you, sir. Dr. Guruprasad, before you answer that question, and again, I just want to highlight this, that, for most of these, the science is not very clear, and we are pretty much looking at what our each other's practice patterns are, and we'll sure hear what Dr. Guruprasad's practice pattern is. And sir, while you answer Dr. Raghu's question, another question in the chat box, which I will tag to it, is favipiravir. So basically, the idea is ivermectin, blah, 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 and favipiravir. Where do you place this and how do you work on it? Dr. Guruprasad.
Yeah, there are a lot of protocols which are doing the rounds. One is something called the Mayo Clinic protocol, where they've used, colchicine and mucinex, etc., for whatever worth it is. And people have. So I'll tell you what the current guidelines are. See, 85% of patients, as you all know, will probably get away with mild illness. So in them, there are some studies have shown that favipiravir actually reduces the viral load. So that some studies have shown, some studies from China are there, but there's no robust evidence about favipiravir. So if we don't have anything, we use something, right? So that's where we are positioning favipiravir, where there's a mild illness. Unfortunately, we don't have a control group till now. We don't have a proper study pattern where we can have a randomized control trial where we have put favipiravir, we administered it, and we have not administered some other person. So as of now, in my practice, I'm using favipiravir for a patient who doesn't have any other contraindications, like patient is not having CLD, patient is not having a chronic kidney disease, and patient's uric acid levels can be monitored. And there's no prior history of gout. So that's where we are positioning favipiravir. The dose is a little high, but unfortunately, there's a 400 milligram tablet available, so the pill burden is low now. So we can use favipiravir. So some people have started using doxycycline because there was some study which showed that in dengue, tetracycline or doxycycline acts as an anti-inflammatory. So there is no robust evidence suggesting that. We use doxycycline with the presumption that if it's an atypical pneumonia, which is causing the same picture as a COVID, or where there's a CORAD 3-4. So we don't miss out on treating the atypical pneumonia, for example, mycoplasma or chlamydia. So the doxycycline or azithromycin comes useful there. Ivermectin, I strongly believe in India, we will never go wrong by giving ivermectin, because the kind of food which we eat, we are all loaded with worms. So every Indian should undergo a deworming. So think of ivermectin as a deworming course for everybody. But as an antiviral, some people say that ivermectin can be used. Some quoting that ICMR has given a guideline that ivermectin can be used for 3 days, and it is used in antiviral. But there is no robust evidence for ivermectin. So the only thing which we have in armamentarium right now is favipiravir for a patient in outpatient department with zinc and vitamin C. I would seriously recommend all my colleagues to take a history of a renal stone disease before we give vitamin C, because a lot of people with renal stones are coming back to urologists saying that our stones are actually, they are coming with hydronephrosis and the stones becoming larger because we have pumped them with vitamin C. 1.5 grams per day I've been taking since COVID started. That's 6 months now. So please be aware of it. Vitamin C actually can precipitate oxalate stones. The patient having renal stone disease, you should be really slow with vitamin C, because there is no evidence that actually vitamin C works. So I think more or less I answered my question. There is no harm in giving ivermectin. The side effect profile is very, very safe. And yeah, favipiravir if there is no other contraindication.
What is the dose, Dr. Guruprasad, of favipiravir?
Favipiravir is approximately initial loading dose is 3,600 milligrams, sir. The 400 milligram tablet actually comes as, we use 4.5 tablets twice daily for day 1. And subsequently, the duration is from somewhere between day 7 to day 14, depending on the symptoms. But there's a warning that we should monitor the patient for the uric acid levels. And this can trigger off a gout in a patient who's susceptible to it. So we should be really careful about it.
What is the maintenance dose after the loading dose?
So it is just half the dose, sir. It's around 1,800 milligrams twice daily. So you give up to 2 tablets BD, 800 milligrams BD for the next 7 to 14 days.
Okay. Thank you.
Let me bring Dr. Kartik, and I will like to bring Dr. Chandra after that. Dr. Kartik, 2 questions for you. One is regarding this anticoagulation. And again, we are not talking particularly about the acute setting, but patients who are at home, and for some reason they got their D-dimer done, it is elevated. We know that in the intensive care, patients who have thrombotic issues, we are giving anticoagulation. But how about these patients who are at home with really no major symptoms but D-dimer elevated? And secondly, Yashoda has any experience with using interferon in these kind of situations?
No, I work in Somajigoda, so we don't use interferon beta. The first part of your question is about the D-dimers, right? So D-dimer is one of those inflammatory markers, and of late, all the evidences that are coming now are pointing towards about the COVID being really an endothelial disease rather than a pulmonary problem, right? So all the therapy that we are basing on now is revolving around the D-dimers. Now, if you have a clinical scenario which is asymptomatic and the other inflammatory markers are near normal and D-dimers are high, I wouldn't like how high is the next question, right? So if the patient is asymptomatic and D-dimers are say about less than 500, then I wouldn't worry much about this patient about giving anticoagulant at home. So I think anticoagulation is to be reserved to those patients who are symptomatic, who are more bedridden, and are under institutional care. Have D-dimers maybe around more than 500, then you would think about starting anticoagulation. So that's my take on the anticoagulation.
Perfect. Thank you so much, Dr. Kartik. Dr. Naveen Chandra, I have 2 specific questions for you.
Yeah, I mean, just to go back to Dr. Kartik's answer, I mean, what we have done is when we designed our protocol, when we have a patient who is level 1C, that is, patient is symptomatic with no desaturation, but is having comorbidities, and we need to have him in an isolation ward in the hospital, we are starting such patients on a prophylactic low molecular weight heparin.
And for
That is
prophylactic,
what we,
you mean 40 milligrams subcutaneous
40
daily, right?
milligram subcutaneous OD, yes.
Right, that's what we're talking about. Sir, since you are on there, I have two questions for you, both from the audience. Number one is, you mentioned about HRCT, like after how many days we should be doing. So if you could throw light on, from the day of onset of symptoms, when should we recommend them to do HRCT, if we should recommend them at all in an outpatient? That is number one. And second, once the guys are positive, do you recommend them to get a routine second test to document that they're negative now? So those are precisely questions for you.
I'll take the second question first. As per the ICMR guidelines and what we also at NIMS follow, if the patient has got a mild disease or an asymptomatic disease, we need not do a second test to prove he's negative. But the issues we come across are domestic issues. Once we have a patient who is, say, level 1C or 1B, probably 1C, who's admitted with us, and we need to discharge him, he is not ready to go back to his house because of his family saying, unless you show us a negative report, please don't come back. These are practical problems we are seeing. But as for the guidelines, definitely second PCR is, I wouldn't do it in this particular situation. Right. And then coming to the first question you asked was on, sorry, just go back to the first question.
So the need for RT-PCR in outpatient setting, and if you do recommend, after how many days?
Yeah, so that's what, okay. So the period is 2 weeks when you repeat a RT-PCR, and if negative, then probably you can, it's a good time to send him home. So 2 weeks, or now even we recommend 17 days or so. So, but ideally 2 weeks is when you would repeat a RT-PCR.
So the question here was that, let's say a patient comes who is positive and he started having symptoms 2 days ago. Would you recommend doing a HRCT on that patient who is otherwise asymptomatic and you have recommended
No,
home isolation?
that's exactly what we discussed in your case setting also initially. I think you have to plan the HRCT as per guidelines is at the discretion of the clinician. There are no, I may be wrong, but there are no really laid down guidelines where you will say you have to do HRCT unless obviously the patient is symptomatic. But in a mild symptoms and so forth, if the patient is persistently having fever for a week or cough persisting, and he looks like he's going to desaturate, or he's probably those patients who have comorbidities, 1 week probably is where I would place a HRCT. I mean, this is just by my experience. I may be, this way, that way. But patient coming day 2 of HRCT is a waste. I think you're just giving money to the labs for them to, thrive upon.
Okay, I have two questions.
Anup,
yes.
can I just answer this question? Just
yes.
I was going through an interesting article in the journal Chest, and then I had a webinar with one of the radiologists where they mentioned that a CT chest is useful to determine the cause of hypoxia. Okay, the pattern of CT chest. So I agree with Dr. Naval Chandra that if there is hypoxemia, I do a CT chest. If there is ground glassing, I'll feel okay, fine. This is just because of COVID causing some kind of alveolar flooding because of the inflammatory mediators. But if there is septal thickening, then the probably, and the ground glassing is not much, then this patient probably is going into something like a microvascular thrombosis, and the fact that he might be going into a pulmonary embolism or a subsequent thromboembolic phenomena is going to be extremely high. So the pattern is extremely high. If you find septal thickening, is going to the thromboembolic phenomena. If there is ground glassing, it is probably the classical, ARDS kind of thing just setting in this patient. So septal thickening has actually correlated a lot with D-dimers. So the treatment actually changes. I go more towards anticoagulating this patient. It might be with your low motor heparin or intravenous heparin, or there is you have oral anticoagulant, direct oral anticoagulants which have been used. So there was some interesting, a lot of actually I think this is too short a forum to discuss about these things, and I think in another setting probably we can talk about the intensive care of COVID, because we are focusing on outpatient care. So I feel that the CT pattern is extremely important for us to determine what way we're going to manage this patient.
Sir, Dr. Guruprasad, while you are there, I'm going to ask you 2 more questions and then we'll move on. It's already 8:32, so I'll try to close in the next 5-6 minutes. So 2 questions for you. Role of steroids in outpatient, and secondly, when fever doesn't break with paracetamol, what do you do? Outpatient.
Yeah, see, the first question, I have seen a lot of physicians initiating Medrol or methylprednisolone or dexamethasone just because the patient had high inflammatory markers. I think that is totally wrong. The recovery trial, which is a fantastic trial done by NHS, says very clearly that unless there is hypoxemia, please don't initiate steroids because you can do more harm than good. So there is no role of steroids unless until there is hypoxemia. Or simple, your pulse oximeter shows saturation 94 or lesser. Till from that time you can initiate steroids. Till that time, there is no other role of steroids unless there's a compelling indication for you to probably put steroids. Or suppose an asthmatic and the bronchospasm is getting triggered off, and or some other compelling this thing is there for you to initiate steroids. Otherwise, for COVID point of view, hypoxia is the point where you're supposed to initiate steroids, right? Second is if the fever is not breaking with paracetamol in a young patient without any other comorbids, probably you can use a small dose of NSAID. But I would really be very careful because the kidneys are also, as you all know, they attack the homins of the ACE2 receptors, and kidneys are full of it. The moment you use an NSAID, probably you can push the patient towards coming into going into a renal failure. But yeah, sometimes NSAIDs do help in breaking the fever. Otherwise, in a patient with having comorbids, probably tepid sponging, and the fever is going to eventually come down. There was an interesting trial called the Greco trial, which was they used Goutnil, which is colchicine, because that's an IL-1 inhibitor, and interleukin-1 works through inflammasomes. So this Greco trial actually used colchicine as one of the agents to break the fever cycle, to reduce the hyperinflammatory response which is going on in COVID.
How about role of steroids in breaking fever?
As I said, Anup, steroids are a double-edged sword. I mean, if the patient is continuously having fever, in all probability, he is going into the hyperimmune phase. That's what my understanding is all about COVID, especially with my experience with COVID.
Okay.
COVID behaves differently than dengue, actually, and that's what I've observed. In classical virals, the fever is very high in the couple of first 3-4 days.
Yeah.
In COVID, I've seen that the fever actually is there for 1-2 days, comes down, patient has cough. 8-9 day again, the fever starts spiking. When the fever starts spiking on the 8-9 day, this patient is going to become hypoxic. That's where obviously your steroids will come into play anyway.
Right. Dr. Shastri, you have a comment, and I will also ask you a question, so you can put up your comment and then also answer my question. My question to you is, COVID positive STEMIs, do you change the anticoagulation course? Do you give them a long? Typically anticoagulate these patients for a day or 2. How do you practice?
So, sorry, I missed the question. In a patient with STEMI, what do you want?
It's STEMI and COVID positive, but sir, there is a lot of noise at your end.
Yeah, go ahead now.
STEMI and COVID positive, but asymptomatic from COVID standpoint. You did a primary test, you are discharging this patient. How long do you continue anticoagulation? Do you give them extended anticoagulation?
Okay. First, to take your question, if the patient doesn't have other features of COVID, generally for STEMI, you give anticoagulation for a week. So I suppose 1 week should be sufficient. Or if you think the extensive thrombus burden is there at the time of STEMI and you happen to have done the angiogram and you see huge thrombus burden, then probably it is nothing wrong in extending up to 2 weeks also. Now, coming to my original comment, I'm not a physician like Guruprasad and other people seeing a lot of patients, but I just want to make my observations and invite their comments. What I notice, the typically patient who recovers, generally they recover very well within 3-4 days, maximum 5 days. And those who go on to develop hyperimmune response, they never become all right. Some or other complaints will be there. They will have either fever or body aches or anorexia, weakness, cough, sore throat, whatever. So typically what I suggest my patients is they ask them to home monitor, and the moment they continue to be worse, not well, you don't recover even after 5-6 days, then you have to be very careful. And that is when you know the patient is going from the viral phase to the immune phase. In the viral phase, it is okay to give remdesivir and probably other supportive medicines. But once the inflammation, there's no point, they should not give steroids at that phase. And you have low threshold to give steroids on day 6, day 7, when they go on develop inflammatory phase, if it is supported by your hypoxia or immune markers. Now, coming to the drugs, Flavipiravir, I know Guruprasad is fond of it, seems to be fond of it, but the Chinese trial, which is very poorly done study, did not show any benefit. Remdesivir, some agreement is there. Ivermectin, you may support on the basis of deworming, but if you really look at the pharmacokinetics, the Monash University study has shown a micromolar concentration, 5,000 micromolar concentration, rather 5 millimolar concentration. And whereas the ivermectin with 12 milligrams once a day, you achieve only 414 nanomoles concentration in the serum. So the pharmacologists argue that there is no way ivermectin helps. But all over the country and probably many places in the world, they are using it. Maybe it is harmless, but I doubt if it is useful. About the anticoagulants, I would prefer to give, especially the home isolation patients, novel oral anticoagulants or direct oral anticoagulants. They are much easier to take. And as somebody pointed out, COVID is essentially an endothelialitis, and anti-inflammatory drugs apart from steroids, colchicine should be useful. Nowadays, in coronary disease, we are using it more often. And similarly, oral anticoagulants is much more convenient to give direct oral anticoagulants. I prefer to give 5 mg BD of Eliquis so that it's convenient for the patient and it's foolproof. By the time B dimer is elevated, already thrombus formation is there. So I would have a lower threshold for any patient extending symptoms beyond 5 days to go on Eliquis 5 mg. These are some of my comments. Thank you.
Perfect. Thank you so much, sir. It's 8:39, so I think we are going to start winding up. I know this topic is...
A small comment.
Another hour. Yes, Dr.
Small comment.
Yes, Dr.
I agree with Dr. Guruprasad that you need to start steroid when hypoxia sets in, but a couple of patients we observed that without steroids, as long as hypoxia is not there, but once hypoxia set in, by the time we started steroids, it's too late. So, as he rightly said, day 8, day 9, if fever is persisting, and even though hypoxia is not there, we're feeling to feel that the inflammatory response has begun even before hypoxia sets in. Maybe there's a role of steroids. Because if you, by the time hypoxia sets in, you may be a bit late in starting steroid.
Perfect. Thank you so much, sir. Dr. Rafi, quick question for you. How to prevent late fibrosis post-COVID? Dr. Rafi, please go ahead. How to prevent late fibrosis? Dr. Rafi, can you hear me? I don't.
Can I answer this?
Yes, please go ahead, because I don't think Dr. Rafi is able to hear me. Yes,
Yeah.
Dr.
Actually, there was an article which people are now quoting to start antifibrotic agents. That was a personal view article in, if I'm not mistaken, either Chest or Lancet. Yeah, it was in Lancet. It was a personal view from one of the pulmonologists who quoted that Perfendon has a role in preventing post-COVID fibrosis, and the dose of Perfendon was same as what was being used in idiopathic pulmonary fibrosis. Nintedanib was also supposed to be useful, but it is too expensive in a setting to use nintedanib. So pulmonologists particularly have started using Perfendon, but there has been a lot of controversy on the use of Perfendon to prevention of fibrosis. Some people have used NIMS system like Mucinex or these combinations, even colchicine to prevent the fibrosis. One thing I've noticed about colchicine, Dr. Anup, is that it obviously, I'm speaking to a cardiologist, so in this acute pericarditis, post-pericarditis, colchicine is supposed to be extremely useful. So I think with the same analogy, if you can use colchicine in a patient who's having COVID and you feel that this patient is actually, fibrosis. So I think colchicine is one agent which we can use. Mucinex can be used because it's not harmful. But Perfendon actually should be taken with a pinch of salt because a lot of pulmonologists are using it. You have to monitor your SGOT, SGPT levels. It causes anorexia, it causes weight loss. So in IPF or UIP, it is completely validated. But in probably in post-COVID, I think more studies are required to actually say that Perfendon is actually useful in these patients.
Perfect. Thank you so much, sir.
One more thing I'll tell you is there's a lot of talk about this long COVID syndrome, which a lot of people are coming up with. They complain with this chest tightness, breathlessness. If you do a CT, it is normal. And they have a lot of this anxiety attacks, panic attacks, which are coming up back to us in the OPD. So this is one challenge which we are facing now, because a lot of now it's beyond 6 months into COVID now and 2 months into probably the spike in India. A lot of people are coming back with COVID, and there are a lot of unnecessary CTs being done. So there's a beautiful article in Chest. I would recommend all the physicians to go through it. They say that till 12 weeks, kindly don't do a CT, because it's not going to the CT findings are not going to resolve. They will take at least 8 to 12 weeks to resolve. And for long COVID syndrome, probably it needs a multidisciplinary treatment with probably a psychiatrist or a psychologist on board to treat these panic attacks. Most of the people will have some dyspnea and exertion, in which there will not be any kind of abnormality in the lung if you see the patient is actually recovering. So a 6-minute walk test is a simple test to see if the patient is actually becoming hypoxic and if the patient is going into actual fibrosis. Because a 6-minute walk test, the patient becomes hypoxic, then yes, you need to look into maybe talk to a pulmonologist and see what can be done. I think a randomized control trial is in place with Perfendon for prevention of post-COVID fibrosis.
Perfect. Thank you so much. If somebody can take 30-second answer to these questions. Saliva-based RT-PCR, I don't know anything about it. Is there anybody who knows? Are we doing it? Is it in India? Is it useful? Saliva-based RT-PCR.
It is being done abroad, not in India as far as.
Okay, thank you. Thank you, Dr. Srirang, for that. Next question. Role of anticoagulation in pregnant patient, COVID positive, asymptomatic, mildly elevated D-dimer. So there is one prothrombotic condition, some D-dimer elevated. Would you give prophylactic low molecular weight heparin in those patients, COVID positive? Anyone can take this question. Dr. Naveen Chandra, how would you take care of this patient? Is he there with us? Yes. Dr. Naval Chandra, pregnant patient.
I don't have much experience on this because we don't get to see these in our institute. Maybe somebody else can take this.
Let me see. Dr. Guru, did you see any such patient? Yes, please.
Yeah, see, if you see even the risk factors, actually pregnancy is a lower risk factor than postpartum. Postpartum is more of a moderate risk for DVT or PT. But pregnancy, if the D-dimer is elevated, then probably, because we know that COVID is a pro-inflammatory, is a pro-coagulant phase. Pregnancy also is a pro-coagulant phase. I would probably use a low molecular heparin, because I would actually if you see a risk-benefit ratio, I think the benefit is more than the risk. So I would go ahead with using a low molecular heparin in this patient.
And the last question on the chat box was role of low-dose aspirin and atorvastatin. This I will answer for the sake of time. I don't think there is any established thought process of giving prophylactic aspirin or atorvastatin. So anyway, we are 46 minutes into the discussion. I would like to close it because otherwise we'll just keep going on and on. We had few guests today who joined us for the first time. So I'm just going to ask closing comments from each of them. Dr. Naval Chandra, what did you think about sessions like these? Do you think that this is a random rant, or do you think this adds value?
No. I think it's a wonderful session. Only thing, one recommendation I would like to give is when you give a heading of home isolation, I think all of us and including the participants should relate our questions only to this, because then you get the actual value of the whole session. So because I'm sure this is an ongoing session and you're going to have many more with pertaining to various situations, let it be moderate situations or critical care situations, then we can keep addressing, because this is like the whole COVID. You can't cover it in a day, you can't cover it in 2 days. So so I think we should limit our questions to the particular session. Just my thought on this.
Perfect, sir. Absolutely valid thought. Dr. Guruprasad, comment for sessions like this.
Yeah, I think, even though Anup has been sending me invite many times, it's the first time I joined the session, and I think he's forced me to do it. But excellent session, Anup. I think especially all the physicians who are on board, when we discuss about a particular topic, it gives us insight about what each one is practicing. And also the medicine is all about evidence-based medicine. So I think, as you said, it's not about quirks and what we feel. I think we are coming to some common platform. If we can just summarize what we discussed, probably if there's a small summary to help out other people who are there in the group, that would really help in terms of recommendations and what they would do in their clinical practice.
Perfect, sir. Absolutely. Dr. Srirang, your comment for the session, please.
It was a wonderful session. Last week I attended, I heard it, today I participated in that. Wonderful experience, both in terms of evidence-based medicines from different physicians and a personal experience. Since COVID is largely based on treatments which don't have a definitive evidence as such, small things regarding the timing of different drugs, what to do when you are placed in a tight situation, hearing from different hospitals and physicians who undergone, it's a wonderful experience and a learning. Thank you.
Dr. Kartik.
This has been first time I'm joining you people, and have been really interesting sessions. So as an intensivist, these are things which hardly I get to see, but I get to follow them up in the case sheets and when I talk to the family, right? So it's a lot of information from all you distinguished people, and it's more a practicality issue also. This discussion brings in that aspect of practicality. We have been reading many papers. We are having, all of us are having robust knowledge, but when it comes to keeping that knowledge onto the paper for the betterment of the patient, and we talk and we bring that practicality issue and how to go about it, it really helps each and every one of us. And thank you for the invitation.
Thank you. Dr. Rafi.
Yeah, Anup, I think I lost when you asked the question.
Yeah.
It was, this is first time I'm joining this session. I think the Huddle sounds like really getting on the very good an exchange of information. I have seen the senior physicians and then different spectrum colleagues. And I think I heard Dr. Guruprasad answering the question. I just wanted to dovetail that answer a bit. Colchicine and mucinex probably, if you're thinking like as the research comes in into the 11th day itself of the clinical symptoms, fibrosis is shown on the CTs. That time, I think Perfenix at least needs about 3 to 4 weeks to really show its effect. So what it means by that is it might not be helpful like if you're starting really early. Probably these long COVIDs with the fibrosis, what we are seeing anecdotally, have to be seen as it comes by with the trials. Post-recovery, it will take a post-recovery stuck with fibrosis. In those patients only, we can actually see whether it actually works. That means it needs at least anywhere between 3 to 6 months of using the medication to see the reversibility of the fibrosis happens or not. I think this is that kind of point I want to add on it. And other than that, I think it was excellent session. I think I'm glad that I'm here and then be able to know new few more people from around the city who are here. Anup, I think excellent session.
Praneeth, I didn't let you speak for the entire session other than the starting. Closing comments for this, and then we will be done.
Okay, the discussion was amazing. Thank you, firstly, all the guests for sharing their thoughts. It was very kind of you for accepting our invitation and being a part of it. Thank you, everyone, for sharing your thoughts. And I think we had a good discussion. Most of the common questions, be it steroids and all, have been very well covered. And just to let you know, there were a few of the general public also who were attending this huddle, which I'm sure the management of COVID or the common questions which run through in the common public also was addressed. So through this huddle, we were trying to make medicine more approachable or reachable to the general public as well. So I hope we continue doing these sessions, and a humble request from everyone to do give a suggestion where we can make this more informative, more useful. So thank you all. This is my final comments.
Okay, thank you so much. All the huddle sessions are recorded. So if you would like to get the recordings of these, just shoot me an email. I will send you that. I also will upload it on Castbox or podcast for you to listen in case if you want somebody else to listen offline, that also can be done. And we are always there listening to your feedback. So if there is anything we can make it better, please let us know. This is a new thing that we started doing. This is our 18th session. We improved a little bit, we deteriorated a little bit, but we do want to continue with this. I thank you, all of you, for coming and joining, and wishing you good night and best of luck. Take care, guys.